In the previous lecture, we studied about thrombosis and embolism in detail. Today, we are going to cover edema, infarction, and congestion. Shock will be covered in a separate video.
What you're looking at are the intricate pathways of the human circulatory system. Every single vessel here has to maintain a perfect balance. Blood needs to flow without any interruption. Fluid must stay exactly where it belongs, because when this balance fails, disease takes over. There's a fundamental rule here. The delicate hydrostatic osmotic balance maintains life, but its disruption triggers a continuous cascade of failure. Today, we're going to observe exactly what happens when this delicate balance tips. We'll carefully trace the entire path, from minor fluid leaks all the way to complete tissue death. This cascade begins with Phase 1, exploring edema and effusions. The very first thing that happens is fluid escapes its proper boundaries. Edema is simply the accumulation of fluid right inside your tissues. It happens when there's a net movement of water from the vasculature directly into the extravascular spaces. We also call these the interstitial spaces. Now, when this exact same fluid accumulates within large body cavities instead, we call it an effusion. Think of fluid movement as a delicate seesaw governed by vascular pressure. On one side, vascular hydrostatic pressure acts as a physical push. It continuously forces fluid out of your blood vessels. On the other side, plasma colloid osmotic pressure acts like a magnetic pull. It draws that fluid back inside. Under normal, healthy conditions, these opposing forces are nearly perfectly balanced. A tiny amount of excess fluid does naturally slip into the tissues, but your lymphatic vessels quietly drain it. They neatly return it to the bloodstream. Edema only occurs when this precise seesaw tips and that balance completely fails. There are exactly 4 structural root causes for this failure. First is increased hydrostatic pressure. This simply means there's too much push. It's usually caused by impaired venous return. A localized block, like a deep vein thrombosis, causes localized edema. A widespread issue, like congestive heart failure, causes systemic, widespread edema. Second is reduced plasma osmotic pressure. This means there's too little pull. It happens when your blood loses a critical protein called albumin. We call this hypoproteinemia. Key triggers for this include nephrotic syndrome, liver cirrhosis, or severe protein malnutrition. Third is sodium and water retention. Retaining salt expands your total blood volume. That directly increases the hydrostatic push, but it also dilutes your existing blood proteins, which decreases the osmotic pull. Finally, we have lymphatic obstruction. If your lymphatic drains are physically blocked, interstitial fluid has nowhere to go. It builds up and causes severe lymphedema. Triggers for this include trauma, invasive tumors, or a parasitic infection called filariasis, which leads to elephantiasis. These 4 structural failures don't just happen in isolation. They actively compound on one another. They form a continuous worsening pathogenesis cycle. One failure feeds directly into the next, steadily accelerating the swelling in the tissues. Let's walk through this cycle. Step 1 begins with hypoproteinemia. This is the primary loss of albumin from the blood. Since albumin is what pulls fluid in, losing it means fluid immediately escapes into the surrounding tissues. Step 2 is the direct physical result of that leak. You now have reduced intravascular volume. There's literally less fluid flowing within your blood vessels. Step 3 follows naturally. Less blood volume leads directly to renal hypoperfusion. Your kidneys sense this critically low blood flow. Step 4 is the body's flawed attempt to fix the problem. The kidneys trigger secondary hyperaldosteronism. They command your body to intensely retain sodium and water. But here's the catch. Your blood still lacks the albumin necessary to hold onto that water. So this extra fluid simply leaks right back out. The cycle loops back to the start, and the edema gets terribly worse. This escaped fluid physically manifests in very different ways, depending entirely on where it lands. Subcutaneous edema pools directly under the skin. It's heavily influenced by gravity. This is why it's perfectly termed dependent edema. If you're standing, you'll see it pooling in your lower legs. If you press a finger deeply into the swollen skin, it leaves a lasting depression. We call this pitting edema. The tissue matrix is literally being separated by water. Conversely, pulmonary edema occurs when fluid aggressively floods the lungs. The lungs actually become 2 to 3 times their normal weight. This condition is immediately life-threatening. The edematous fluid completely fills up the tiny air sacs, called alveoli. It severely blocks gas exchange. It directly causes hypoxia. The patient physically cannot absorb oxygen. Now, when this exact same fluid completely fills internal body cavities, it's known as an effusion, and there are 2 very distinct types. A transudate is clear and straw-colored, it's extremely protein-poor, and it's entirely non-inflammatory. A transudate is driven strictly by the pressure imbalances we just talked about. The walls of the blood vessels themselves remain physically intact. In sharp contrast, an exudate is thick and cloudy. It is very protein-rich, and it's highly inflammatory. An exudate happens because the blood vessel walls themselves become highly permeable. Large proteins and specialized immune cells physically escape right into the body cavity. As our journey continues, we move right into phase 2, hypervolemia and congestion. We're moving beyond simple fluid leakage now. Let's look at what happens when the actual volume of red blood cells increases directly within the tissues. Both hyperemia and congestion mean there's more blood within a specific tissue, but their underlying mechanisms are complete opposites. Hyperemia is a purely active process. The arteriole actively dilates. More fresh blood forcefully flows into the tissue. Because this blood is highly oxygenated, the tissue instantly turns bright red. This active redness is medically called erythemia. It happens naturally at sites of inflammation or even in your skeletal muscles during intense exercise. Congestion, however, is a completely passive process. The venous outflow is either constricted or sluggish. Old, deoxygenated blood passively backs up. The tissue turns a dark blue-red color. We call this cyanosis. It happens during systemic cardiac failure or behind a localized venous obstruction. This passive venous congestion is incredibly destructive over time. During acute pulmonary congestion, the capillaries suddenly become fully engorged with backed-up blood. The septal walls in the lungs begin to swell with fresh edema. As this transitions into chronic passive congestion, that long-standing stagnant blood causes permanent ischemic tissue injury. The delicate lung septa become thick. They become permanently scarred with heavy fibrosis. Inside the alveoli, specialized immune macrophages physically swallow the backed-up dead red blood cells. These macrophages become totally loaded with an iron pigment called hemosiderin. We call these heart failure cells. They are the absolute marker of chronic venous backup in the lung. This exact same passive backup aggressively damages the liver, too. In the acute phase, the central veins and surrounding sinusoids simply distend with excess blood. But as this precise congestion becomes chronic, a highly distinct pattern emerges. Red, dying areas of profound hemorrhage and necrosis surround the central veins. These dying areas sit directly next to tan areas of fully viable tissue. This alternating pattern of death and survival physically resembles the grated surface of a nutmeg seed. Therefore, it's classically referred to as the nutmeg liver. It is the absolute defining hallmark of chronic passive hepatic congestion. If this passive congestion continues to worsen, we naturally arrive at phase 3, the mechanisms of infarction. This is the ultimate consequence of our continuous cascade. We've reached total vessel blockade. We've arrived at irreversible tissue death. An infarction is simply an area of ischemic necrosis. This means the living tissue dies because its vital blood supply is totally cut off. The vast majority of all infarcts are caused by simple arterial thrombosis or an embolism. A solid clot completely plugs the artery. Other, less common causes include local vasospasm. This is where the vessel violently and tightly constricts itself. Next is extrinsic compression. This occurs when something heavy, like a tumor, physically crushes the vessel closed from the outside. Finally, we have torsion. This happens when the blood vessels physically twist, pinching themselves off completely. Now, venous thrombosis certainly can cause an infarction. However, it usually only results in passive congestion. This is because alternative, parallel bypass channels generally open up to permit the blood to flow out. Arterial blockage, on the other hand, is far more immediate and fatal.
It's important to know that not all infarcts look exactly the same. They're broadly separated into two extremely distinct visual classifications. First, we have red or hemorrhagic infarcts. These are heavily filled with pooled blood. Second, we have white or anemic infarcts. These are utterly pale and completely devoid of blood. The existing physical architecture of the specific organ dictates exactly which type of infarct will occur.
Structurally, a red infarct acts a lot like a broken pipe leaking deep into a spongy material. This specific type of infarct happens in loose, spongy tissues like the lung. It also happens in tissues uniquely equipped with dual blood circulations, like the lung and the small intestine. Blood simply flows from an unobstructed parallel vessel right into the dying zone. It actively pools in the loose tissue. This makes the entire area appear deeply red. Structurally, a white infarct acts like a pipe firmly stuck inside a solid concrete block. This specific type of infarct only happens in solid organs with strict end arterial circulation. The human heart, the spleen, and the kidneys are prime examples. The extreme physical density of the solid tissue literally prevents any fresh blood from seeping in from neighboring beds. The entirely dead area remains completely pale, it's highly anemic, and it typically presents in a distinct wedge shape.
When we meticulously examine this dead tissue under a microscope, we observe very specific types of cellular destruction, or necrosis. Ischemic coagulative necrosis is the absolute standard. It's the dominant characteristic of the vast majority of all infarcts. The tissue thoroughly dies, but its underlying physical architecture remains beautifully preserved for days afterward. Liquefactive necrosis, however, presents a major exception. The central nervous system behaves entirely differently. An infarction inside the brain does not preserve any architecture at all. It rapidly dissolves the dead brain tissue into a shapeless, liquid mass. Finally, septic infarction is a catastrophic event. It occurs when live microbes physically seed the dead necrotic tissue. It often happens when an infected heart valve vegetates and forcefully shoots off a bacterial embolus. The microbes rapidly infect the dead tissue. They entirely convert the cold infarct into a highly active, infected abscess.
Now, even when a total occlusion occurs, immediate tissue death isn't always guaranteed. There are exactly 4 critical variables at play. These 4 specific variables are the modifiers of occlusion. They dictate precisely whether the tissue will ultimately survive or die.
First is the precise anatomy of the vascular supply. This is the single most critical determinant. The presence of an alternative, backup blood supply strongly dictates survival. Second is the absolute rate of the occlusion. A slowly developing blockage is much safer. It allows precious time for entirely new collateral pathways to form. Third is tissue vulnerability. Different specific cell types possess vastly different baseline tolerances to ischemia. Fourth is total blood oxygenation. Low systemic oxygen levels are called hypoxemia. Having hypoxemia vastly increases both the likelihood and the overall geographic extent of a fatal infarction.
The sheer variation in tissue vulnerability dictates exact cell survival capability directly against minutes of total ischemia. And the visible contrast is severe. Central nervous system neurons are incredibly sensitive. They suffer total, irreversible death after just 3 to 4 very short minutes without blood flow. Myocardial, or heart muscle cells, are incredibly resilient in comparison. They can strongly sustain viability for a full 20 to 30 minutes before truly irreversible necrosis finally begins. The exact same vascular blockage yields vastly different clinical outcomes, and it depends entirely on the specific cell type involved.
The entire human hemodynamic system operates precisely as a single interconnected continuum. Fluid imbalance, vascular pooling, and final tissue necrosis are never isolated events. They are strictly compounding stages of a single vascular failure. Think about it. Congestive heart failure actively causes a systemic venous backup. This causes a massive, immediate pressure spike, completely tipping that delicate vascular seesaw. This forces a rapid fluid escape. It severely floods the lungs with pulmonary effusions. This fluid physically creates a total oxygen blockade, completely halting all gas exchange. Ultimately, the stagnant, congested blood flow and the profound hypoxemia push the tissues completely past their time to death thresholds. The absolute final result is total ischemic necrosis.